So as mentioned earlier, we will now move into the panel portion of today. And each of the panelists will give you 7 minutes on their subject matter expertise, which is starting off with collaboration and learning network, moving to research, then quality improvement, and then the patient/family parent perspective. Please take note that after the 4 panelists have given their talks, we will have a 5-minute transition period. During that period, you will have the opportunity to dive deeper into one of those 4 areas in a breakout session hosted by the panelists presenting, as well as a co-lead and a facilitator. So as you will hear these panelists speak, the last slide, when Tawanna has finished her talk, will include instructions, which will also be in the chat box, about how to enter the breakout rooms, which we will then do, and then for half an hour have a more in-depth discussion, and then we will return for the close all together. And so with that, I will kick it over to Allison. Thank you, Allison.
Thank you. Let's see. Okay. So hi, my name is Allison. And this is just a quick outline of what I'm going to talk about today. I'll give you a little bit of background about All Children Thrive and the anti-racism team, why we are working to address racism, what we did, what we've learned, and ways forward. So All Children Thrive is a learning collaborative centered around addressing social influence of health. It is based on the Institute of Medicine's Learning Healthcare Systems model. It's a convener of improvement teams with members from the healthcare system, community organizations like social service agencies and local nonprofits, the public school system, as well as parents from across the community. I'm talking to you today as the project lead for the anti-racism team within All Children Thrive. Our aim is to create an anti-racist environment within the All Children Thrive network so that we might address health disparities across all improvement teams. So an anti-racist environment means that we are working to dismantle structural racism through our words and actions. Our team includes an improvement lead, researcher, community engagement consultant, and project manager, and we all work together to put together this slideshow. I just happen to be the person who's speaking to you. So why address racism? We were really led by community voice. So every quarter we have an All Children Thrive learning session. All of our improvement teams get together and we present out projects, our improvement projects, where we're at, what we've learned, if we have results. And during one of those sessions, parents called out the need to address racism in order to reach our goals. And so we heard those voices, and we started having conversations within our network. And what we heard was that we really needed capability building around anti-racism within CCHMC, within anti-racism, or within All Children Thrive, in order to address this. We also looked at our data and saw across internal and external work streams there were disparities in health outcomes like asthma and diabetes, social emotional outcomes, educational achievement outcomes, eviction rates, etc. So we organized. I mentioned our anti-racism team. I'll show you our key driver diagram and take you through each one of these steps. So this is our key driver diagram, and just a quick level set on this. On the left, you have our global aim, which I mentioned before, and then our SMART aim and our population. And then the key drivers that I'm talking about today, so these are the things that we feel are really, based on our theory, are necessary in order to complete the work. So we need to engage racial equity content experts. We need to have a safe space encouraging anti-racism. And we have to have engaged employees and leadership that foster anti-racism. We also need effective data, and we need to establish and enforce anti-racist values and policies. The first 3 are the ones that I'm going to focus on today and talk to you a little bit about the intervention that we implemented. So before we did anything, we tried to build will because we felt like that was really important. We built a key stakeholder diagram, and we really considered the level of current support for anti-racism work when thinking about each stakeholder, and then how critical to the success of this work each stakeholder was, and we mapped that. And then we went and talked to people, staff, faculty, leadership, and we wanted to know where they thought we should start, what had been done, what worked, what didn't work, and what people were willing to support and in what ways. And we had some fails, right? So some false starts. So we had to rescope. We originally were going to go, we'll start at the organizational level, the internal organization of All Children Thrive, and quickly found that we needed to start smaller. Team member selection, we wanted to include people who were ready to do this work, but we also wanted to hear from naysayers, and it took us a little while to find a good balance. There was fear associated with this work. White privilege and fragility were important things to recognize. So as a white person in this work, I can be passionate, I can be invested, I have not experienced racism. So I have to keep that in mind when I'm doing this work. What's getting in the way, and should it be? The answer is probably not. And then also making sure that we are not centering around white narratives, and that we are considering the narratives of people of color and Black people when we're designing everything that we do. And then also measurement is just a huge challenge in this space. So our intervention is called Coffee and Conversations. It focuses on the All Children Thrive staff. This is a controlled population, but we've added people over time based on the comfort of the group. This decreases the impact of hierarchy, so we don't have leadership involved in this particular group. And many of these people are different levels of leaned in, so different levels of comfort, different levels of awareness. So it's an anti-racism capability building meeting. We have it every 6 to 8 weeks. It's been going on since November of 2019. We follow an anti-racism framework. This is not a linear framework. We spend a lot of time in education, self-interrogation, and then based on those, we develop action steps forward in our personal and professional lives. We use case studies and lived experience to guide this curriculum. So what we've learned, this work is essential to accomplishing All Children Thrive's goals. Context and culture of our environment are important. They cannot be ignored when we're designing and implementing our interventions. Verbal support at the leadership level is pretty easy to get. Action is a bit harder. Anti-racism policy and resources are needed. Measurement continues to be a challenge. Ways forward, naming racism, you have to do it. Understanding and interrogating how racism impacts the goals that you're trying to achieve is so important. Calling it out on your KDD, in your strategic plan, in your programs, in your policies, these are musts. Setting aside time for personal and professional education, as this is an ongoing journey. Asking for help from experts inside and outside the institution and/or network. And then start where you are. So focus on what you have, not what you don't have. Focus on the strengths of your people, your organization, and your data, and then get started. Thank you.
Thank you very much, Allison. Anita, we look forward to your presentation on research within health disparities.
Thank you. So I'm going to be talking to you today about some background studies that have been done on racial disparities in congenital heart disease, presenting the results of a completed study of the Fetal Heart Society Research Collaborative, looking on disparities in prenatal detection of congenital heart disease, and then talk about future directions for multi-center collaboration. These are my disclosures. And the Fetal Heart Society has several institutional sponsors that are listed at the bottom of the slide. So this publication from the Institute of Medicine came out in 2003, describing double jeopardy, which is a concept that the same disease processes have compounded risks for groups that experience inequities. And almost 2 decades later, we are still talking about the same things. We know that what happens in utero can influence the health of populations for generations. So with that in mind, the goal of my study was to determine whether socioeconomic status, insurance type, vulnerable race and ethnic group, and at-risk geographic locations are associated with lower rates of prenatal detection of HLHS, hypoplastic left heart syndrome, and detransposition of the great arteries. And the secondary aim was to determine whether these factors correlated with worse short-term outcomes. This was a study of 21 centers, 19 in the US and 2 in Canada, and the site PIs are all listed here. So just some background, about 21% of children in the US live in poverty and 43% near poverty, and I expect that these may go up over the next few years. Poverty rates are highest among Black, Hispanic, and Native American children and vary geographically. We know that prenatal detection of congenital heart disease is beneficial because it allows for appropriate delivery planning, and that middle to lower socioeconomic status families experience higher stress levels from their congenital heart defects, even from short hospital stays. This is the level of care organization at our hospital. So all babies with a prenatal diagnosis of HLHS or DTGA are delivered in close proximity to the tertiary care center. My Quartermain study in 2015 showed significant geographic variability in the prenatal detection of congenital heart disease. And another study from Dr. Iles in 2014 looking at CDC data suggested that Hispanic ethnicity may be a barrier to prenatal detection. Shabnam Pevandi at UCSF has done work evaluating the relationship between Hispanic ethnicity and one-year outcomes in DTGA and HLHS in California. She found that Hispanic ethnicity was associated with poorer one-year outcomes. And then she did something called a mediation analysis where she looked at 7 possible intermediaries in this pathway and found that both maternal insurance and education were mediators. So the study that I did was a retrospective cohort study using data that was collected from institutional databases of the 21 centers. And I derived my socioeconomic variables using a specialized software package. It would basically take a patient's address and then access census data to create a variety of different parameters. I calculated something called the neighborhood summary score, which looks at 6 components of wealth and income. That was for US patients. And then for Canadian patients, used something called the Chan Index as a measure of socioeconomic status. And this has been validated in adults for coronary artery disease studies. This is the overall demographics of the study population. So I looked at about 1,800 patients with HLHS and DTGA from the US and Canada. The race and ethnicity distribution was fairly comparable to the US Census. Also looked at insurance status, private versus public, rural or not, rural or urban location, and then driving distance to the surgical center in miles and minutes. What we found is that in our cohort, hypoplastic left heart syndrome was prenatally diagnosed in about 92% of patients, so that's actually pretty good. And TGA was prenatally detected in about 58% of patients. If you look at this graph here, you can see increasing wealth on the bottom and prenatal detection rates. And so for both HLHS and TGA, there was a striking increase in prenatal detection rates with increasing wealth. We also found that Hispanic ethnicity was associated with lower rates of prenatal detection, as was being in a rural location. I looked at some modifiers and found that maternal age, increasing maternal age was associated with prenatal detection, and multiple gestation pregnancy was also associated with higher rates. So this is interesting. You can see that almost all the babies in multiple gestation pregnancies that had heart disease were prenatally detected, suggesting that these patients are diverted to specialist care. It's not advancing. And then in regards to the secondary aim of looking at outcomes data, I'm going to show you the positive results, or show you the factors that were associated with lower mortality. So Hispanic ethnicity was associated with a significantly higher preoperative mortality. And we found that Black infants had significantly higher 30-day surgical mortality, as well as hospital, as death prior to discharge from the hospital. Dr. Pebandi did a mediation analysis on this data and found that while birth weight mediated a portion of the effect on outcomes, it certainly wasn't the only factor, and so significant future work is needed. So I wanted to leave you with that as a starting point for a call to action. We know that racial disparities in cardiovascular outcomes have existed for decades, although the scope of the COVID-19 pandemic is bringing them to the forefront. And the next phase of research will require action-oriented clinical trials to begin to address these disparities. And I think multi-center working groups such as these are a powerful mechanism to start these trials.
Anita, thank you very much. And now we'll move on to Elissa, who'll be talking about quality improvement and the ability to use it as a tool in racial disparities.
Hi, thank you so much for inviting me to present today. And I just want to say how much I've enjoyed the presentation so far and how honored I am to be presenting with such a knowledgeable set of people who are working on topics I'm interested in. It's great to be a part of this. I don't have any disclosures. I just have a minor disclosure to say thank you to one of my colleagues, Dr. Casey Lyon, who is, that just went forward without me. I don't know why. One of my colleagues, Dr. Casey Lyon, who's an assistant professor of pediatrics at Seattle Children's Hospital, who really co-developed these slides with me and teaches similar versions of some of these topics around QI and disparities. So I just wanted to thank her for that contribution. So we've heard already from some of our great speakers already that, we have been talking about unequal treatment and racial and ethnic disparities in healthcare for the past several decades. Dr. Krishnan just mentioned the 2009 report that was almost, over a decade ago on race, ethnicity, and language data. It says that we should be looking at, it really was a call to action even back then to analyze all QI data, looking at disparities like race, ethnicity, and language. But since then, I really want to, not that it is the most current, but unfortunately, this is not routinely happening with QI studies, as illustrated by this Liu paper that you see on the bottom. They conducted a secondary analysis of a systematic review of about 278 adult diabetes-related QI studies and found that only 35% of those studies considered equity. And that percent has not increased much in the last decade. They also found that 2/3 of the studies that considered equity took a targeted approach, looking specifically at equity, which we'll talk about a little bit more in a minute, and only 1/3 were general studies that conducted subgroup analysis, kind of like what we've been seeing in some of the earlier presentations. It's striking, although perhaps not surprising, especially given what we've been hearing this afternoon, as those subgroup analyses should be easier to do, but we're not doing them. And it's particularly unfortunate because the general studies are more likely to propagate or increase disparities, but disparities weren't the primary focus of most of those projects. So even though we've been talking a lot about it, like QI isn't necessarily being harnessed in the way that it could be to look at disparities. And maybe more now, so. And so there are really two ways to think about QI and disparities. And I sort of mentioned that on the last slide. So there's the applying the equity lens to QI. So you're doing your QI project to improve access to patients in your clinic or to reduce central line associated bloodstream infections in all of the units in your hospital or whatever your QI intervention may be. So you're doing this general system intervention. And then after the intervention, you pull out your data and look at subgroup analyses by race, ethnicity, language, rural, urban, whatever the disparities are that you're looking at. But really, it's most useful if you can do that in the intervention design phase of it, right? Not retroactively, but earlier when you're actually thinking about the intervention. So that's just one way that people who are already doing QI projects can start thinking about incorporating an equity lens into what they're already doing. Another option is to apply a QI lens to equity. And so you identify that there is a disparity between different groups in a particular area that your team or yourself or your hospital or your health system or community, whatever it is, and you try to use QI to reduce that disparity and improve equity. And so you're still doing QI, you're still trying to improve things for the whole group, but you're really trying to decrease disparities. And so you're targeting interventions, you're choosing interventions specifically that are going to have a greater impact on the underserved group that is your focus. So can we actually do this? Basically, there are let me take a step back. When I first started doing quality improvement a very long time ago, the sort of traditional line was that a rising tide is going to lift all boats, right? But it turns out that a rising tide lifts different boats at different rates. And so really, there are three possible ways that QI interventions, while improving things, may have an impact on disparities. So the first option is that you improve your CLABSI rates or you improve hospital-acquired infections or vaccination rates. And you do this and it sort of improves quality at the same rate for all groups. So if there were pre-existing disparities, they continue to exist. Then, where does this number? Okay. There are targeted interventions, or perhaps unintentionally, there are QI interventions that might disproportionately benefit an underserved group. And so you're improving disparities. So maybe you're making everything better, but you're sort of closing the gap between this disparity that might have existed between different groups. And then there's the unfortunate, if you're not paying attention and you're not thinking through how your intervention is going to impact different groups or how it's going to work in your particular system, there's going to be differential uptake or effect by different groups, and you're going to make the disparities worse. So you might have an intervention that is more effective for highly educated, high income white people living in an urban area, and it's going to be less effective. So it may make things better for them, but widen the gap between outcomes for them and for underserved or minority groups. So here is an example of the first scenario that we talked about, the two options of the QI disparities, where we're applying an equity lens to an ongoing QI project. This is a Medicare-funded QI project focused on monitoring patient outcomes, using feedback on performance data and educating clinicians. In this particular example, the project had selected urea reduction ratio as an indicator of adequate hemodialysis dose. The proportion of all patients, as you can see, who had adequate hemodialysis dose increased twofold over the course of the project, which was quite a long project. And the gap between the white patients and the Black patients, so the upper line and the lower line, decreased from a starting point of 10% to 3%. And the gap you can see on the right-hand side between female and male patients decreased from 23% to 9%. And I said it's a pretty long project, longer than some of our QI projects. This was over 7 years. They looked at a couple of other disparities, race and sex disparities in anemia and nutritional status and things like this. But in this particular project, they did reduce some of the disparities in a project that was already ongoing where they were trying to improve things for the general population. This is a different approach. It's sort of that second option where they're applying QI approaches to reducing disparities and improving equity as the focus of it. So this study published in JAMA in 2015 reviewed all patients discharged from Le Bon-Hur Children's Hospital, PICU, between the beginning of 2007 and the end of 2012. They had initially found there that Latino children at the institution had a higher odds of mortality. And so what they wanted to do was actually take QI projects and focus QI interventions and strategies to address this disparity. And so the study evaluated the effect of a multi-level healthcare intervention aimed specifically at reducing PICU mortality among Latino children. So the intervention, this multi-level intervention, involved patient, hospital, and community level interventions, education of the healthcare team, recruitment of bilingual staff, increased access of 24-hour interpreter services in the emergency department and the PICU. They translated consent forms and educational materials for parents. They tailored their end-of-life care discussions to be culturally competent and sensitive, together with palliative care services. They did outreach efforts and contacts with the Latino community to remove barriers to healthcare access. And then they also additionally got help from the city government and local health departments for preventive services. And as you can see here, not only did they sort of close that gap, but they actually even reduced the mortality rate for Latino children to that below of white and African American. And so I realized that that is a very complex and multi-level intervention across the entire institution. But when all of those different stakeholders work together, really targeted on reducing disparities, it might be that you have to have lots of concurrent or collaborative interventions, but they can really make a huge difference, as you can see. So how do you avoid worsening disparities with your QI project? At the very worst, and at the best, actually reduce disparities using your QI project. Well, so really, this is sort of the nitty-gritty of the how to do it, and we're going to talk a little bit more about that in the breakout session, so join us if you're interested. But really the first thing is you need to understand your system at baseline, both overall and with regard to specific subgroups and potential interactions. And we started to see that with lots of the presentations that we heard earlier this afternoon, both that we know that these disparities exist in various outcomes and with particular groups, or that we don't even have the data yet, and that's a great place to start, is just to start stratifying your data by different groups of interest. And then you could start to think about how interactions might affect different parts of the system and different subgroups within it. The second is to understand your intervention itself. So thinking both about the putative mechanism, like how is this intervention going to change the system, and then its intended targets. So is the intervention is it going to work differently on different groups because of language or because of health literacy, or because if people don't have access to health information, health technology, then and maybe a healthcare app on your phone isn't going to be particularly helpful. And then the third is to understand your context, and I think a lot of that is what we've been talking about this afternoon. And it can sort of seem overwhelming, but some of the ways to be really specific about it, when we're thinking about using QI to improve our standardization or using evidence-based best practices, think about how your context differs from the context in which the intervention was developed and the factors that may influence uptake and effectiveness. So really think about all of the stakeholders and all of the factors, and there are we could talk about context. I'm a medical anthropologist. We could talk about context for days. But those are sort of the big things to think about when you're thinking about whether you want to apply a QI lens to equity or apply equity to a QI project that you're already doing. So some of the things that you need to think about, it is and could be and should be considered as part of every QI intervention and evaluation from the outset. It's great to do it retrospectively and when you're analyzing your data at the end, but really every quality improvement project has the potential to improve equity. And you can do that by gathering and tracking outcomes stratified by socio-demographic characteristics, particularly the ones of interest in your population. And then pay attention to the ways in which your baseline relationships, interventions, and contexts may vary across different groups. And so you can choose your interventions accordingly. You know, we always, with a QI project, want to choose provider education as like the magic bullet, but really think about what interventions are going to have the highest impact. And then really, like I said, that's the key to not worsening disparities, but potentially improving them. Thank you.
Thank you very much. Appreciate it. We'll now move on to Tawanna, who will provide the parent perspective.
Hello, everyone. Please take a look at my slides, but know that my slides are not going to directly correlate with what I'm speaking about. I had to combine 4.5 years of being a congenital heart parent into about 7 minutes. And so I chose to provide my background information on the slides, but to continue speaking as we went along. So in recap, my name is Tawanna Nishibayashi. I'm a heart mom and advocate for congenital heart defects. I am a volunteer director, for the Children's Heart Foundation's Illinois region, and I am a consultant for racial equity. My daughter, Avery Grace, was born with HLHS with a complication of moderate to severe tricuspid valve regurgitation and has had 5 open heart surgeries. The last 2 were for a Berlin heart and a subsequent heart transplant 4 months later. We cannot make improvements until we are aware of our shortcomings. I am here today to help shed light and hopefully create awareness with my firsthand experience of the disparity that exists within the healthcare arena for people of color. Disparity is not unique to the Black community. As an immigrant, woman, or someone who lives with a chronic illness or disability, you're familiar with the concept of having to work and try harder than others simply to get a seat at the table. Chances are more scarce when you do not look like the prevailing experience. Systemic racism and all of its constructs have simply made this reality the forefront of the Black narrative. For people of color, and Black people in general, the effects are more wide-reaching than any of the other groups that I listed above. Systemic racism and implicit bias place me at a deficit, without question, every single day. The idea of being born Black leaving you steps behind zero is a valid concern. When you add in other life circumstances, you may not have the ability to see the starting line. When people look at me, or hear and see my name, as Jamila mentioned earlier, I am already at a double negative as a Black woman. There are a set of biases that imply a myriad of things about my character and capabilities. That equates to me working harder from the start. As clinicians, you all have fostered the ability to compartmentalize and normalize in order to best do your jobs each day. You still feel, but you cannot allow yourself to feel everything, or it has the potential to cloud your decision-making when caring for a patient. It could spill over into your home life and lead to burnout and career changes if you do. The ability to create a professional distance is a healthy one. Even still, there are unconscious biases that slip through the cracks, and these unconscious biases lead to disparity in care, often unintentional, but sometimes not. As a parent of a medically fragile child, there is no compartmentalizing. This is life. You live in a heightened state of awareness at all times. Imagine being in a situation that you hope and pray no one has to be in, that of having a child with a rare and severe congenital heart defect. That, in and of itself, puts you at a huge deficit of the learning curve necessary to go about taking the steps necessary to save your child's life. You look around, and there are no doctors that look like you. There aren't as many families that look like yours. You have a strange diagnosis and a new reality hyperimposed over the fact that you are a double negative, a Black woman that is less likely to be taken seriously than almost any other patient combination. You know that racial and ethnic minorities receive lower quality healthcare than their white peers, even when insurance, status, income, age, comorbidities, and severity of conditions are comparable, and that minority persons are less likely to be given appropriate cardiac care. So I made a pledge to myself that I was not going to allow this to happen to my child. Therefore, I had a lot of work to do. I had to research and study, ask the same questions 3 times to 3 different individuals at minimum. I had to make sure my child's baseline and reactions were my most important purpose, While at this point, we are all accustomed to going about our daily lives with literal masks due to COVID, I had to put on a theoretical mask each day to intentionally counteract the implicit biases that I was met with at first impression. While I was living through the unimaginable and supporting my child through varying stages of fighting for her life, it's akin to going to work each day, a second job, as you reject stereotypes in an effort to be seen, an effort to be heard, an effort for your advocacy to be validated by those who hold your child's life in their hands. I was up at 5 a.m. every day after a sleepless night on the hospital room couch to dress immaculately, yet my white heart mom counterparts would show up for rounds in pajamas with their hair in messy buns. I interacted with my daughter's team only to meet surprise and compliments at my ability to speak legibly and articulate and retain information about my daughter's care. I dealt with consistent surprise on my overall knowledge and ability to retain information. You come into contact with those who still want to dismiss you and not take you seriously. So I reckoned myself once again to being referred to as the one word that people like to toss at strong women that are deemed to be aggressive, and cast as the angry, intense Black woman when my white heart mom friends were having the same interactions being praised for being strong advocates. I've been called names that they weren't aware that I overheard by nurses and doctors more times than I can count. The onus was and is on me to actively dispel stereotypes daily in one of the most stressful and traumatic experiences that one can go through. Repeatedly, every hospital stay, every new fellow, attending or medical staff that I encountered. It was a layered responsibility that my white counterparts do not have to contend with, and an extra added layer of stress that wasn't conducive to my overall well-being as I navigated the unimaginable. I became tasked with building alliances so that the understanding of who I am and my reputation precedes itself. My daughter was attached to a Berlin her fighting for her life with a nearly 50% mortality rate as I was still forced to fight to be seen and heard. I personally know how to assimilate, overcome, and attempt to level the playing field. But what of those that lack that capability? The parental relationship and ability to care for their complex child can be the difference between quality of life or life and death. Yet I had to fight to be treated as an equal advocate for my child's care and remind those that I had a say in the decisions that were made for her. I've been in and out of the hospital alongside my daughter for the last 4 years, 5 open heart surgeries and countless procedures. When she is inpatient, so am I. I largely don't leave until she does. During that time spent in our children's hospital that I love, that lies in a diverse major city in the United States, there were only 2 Black attendings, including one of direct African descent. There were no Black fellows and very few non-white fellows. There were 2 on the nursing staff of our unit, and that was only after a recent hire during our last hospital stay and the 3rd year of my daughter's life. Representation is important. It matters. It matters to see someone who looks like you for a variety of reasons, to inspire comfort and understanding, to inspire hope, to feel as if there is someone you can trust or who is on your side. Racism happens in hospital settings, as in life, every day. Seeing someone that you or your child can relate to helps to make you feel included, to know that it's a safe space and inspire trust that someone will do right by you and maybe you don't have to quite fight as hard. Because it's been proven time and again that you do not inalienably have that right. Representation needs to be a priority across the board and it must never stop. Our hospitals and healthcare in general should encompass and embody diversity and inclusion and more than the tokenism that currently exists without real representation and equity, our keyword of the day. Having a diversity and inclusion program or staff member that is largely present in name only or once yearly check-ins will never lead to representation and equity for all. A hospital can be and has been my home away from home, but when I'm living in my second home, I'm always on guard. I'm always the representative, and it's work. It's work to be one of the few members of color bearing the weight of expectation and questions for the greater whole. It's work to do the emotional labor of police pointing out problematic racist thinking, policies, actions, and statements, while attempting to avoid the very bitterness and cynicism that may then translate into the stereotype of angry Black woman. That very stereotype that I toe the line so as not to trigger has the opportunity to undermine my advocacy on behalf of my child. There isn't much commonality and comfort for me as I fear and fight for my daughter's life. There's me, on edge, dispelling stereotypes with each calculated move, just to be taken seriously while being labeled difficult. But I go back to those who find themselves in that situation and in this dynamic and they don't share my skill set. For the patients who lack the wherewithal to try to get around the system and are instead lost within and beat down, that we've heard about examples throughout this speech of people that are being left out. Having representatives around those individuals can mean the difference in the care that they're able to provide for the child. We've alluded to the non-English speaking population and what the disparity is for them. But if you have a non-English speaking patient, they're provided with a translator. What of, in effect, doing the same for families of color? a peer representative or patient experience or relations role that represents them, a social worker with the ability to meet them where they are at, and staff and patient equity team that checks in with all staff and all patients periodically. What if they were met with a center where there were team members trained and well-versed in equity that ensured their clinician and patient experience was an inclusive and an unbiased one? What do these families have? How do you bridge the divide where you're comfortable relating to those families and providing the same level of care despite differences in experience? How can you learn about that experience and utilize it to inform your interactions and decisions? How can you move past the discomfort to truly challenge bias? And there will be uncomfortable conversations, but through things that are uncomfortable, that's where your growth lies. How different would your center and unit experiences be if you provided Black patient liaisons and social workers, partnered with historically Black churches instead of having a chaplain for all, had fellow medically fragile parent peers that share their racial background as assigned mentors? I've been that person on my floor in my unit just because there wasn't anyone to do that for me, and so I took it upon myself to be the welcoming committee and to let them know that they had a voice and to explain diagnoses. Did this for free during the hospital stay. It shouldn't have been my role in addition to taking care of my child. What would it look like if there were an equity ambassador on site, or if there were annual equity check-in surveys and mandatory workshops throughout the year? All the things that I mentioned and more that we'll speak about in all of our varying racial or breakout sessions. These are things that need to begin happening now in order for a difference to be felt a year from now. So if after hearing everything today, you've been able to kind of take a look at your institution and even yourself and ask yourself some hard questions, and you feel that you've been trying, I ask you to take a look and examine your program to see if there are some more advantageous evolutionary steps that you can take. You're trying, but what has that trying translated into? And has that, is that trying enough? And if after you absorb this and other information, you can take a step back and be really honest with yourselves and your center and see where it's at, and you see that your organization has not begun to do this work, I challenge you to take everything that you absorbed today back to your program and just create 2 steps to begin. That's it, just 2. It can be that simple when we're starting at a deficit. It all comes back to taking action now to change the infrastructure of your institution, making it a place where racial health disparities are actively dispelled versus perpetuated, which is currently what's happening across the country. Lives depend on it. I speak a lot about awareness because awareness informs change. But now that we've begun to create this awareness, the ball is in all of our courts to actually do something about it. Thank you.
Tawanna, thank you very much for the powerful words. Thank you as well to Elissa, Anita, and Allison. As mentioned earlier, we are trying to cover an awful lot in these 2 hours. We will try our very best to hustle through this break and into the breakout sessions, and we need to be back together at 10 till and no later. For those that are interested in the various breakout sessions, the instructions of how to get there are in your chat box. For those who are staying in the Collaborative Learning Network breakout, you will just remain on this line. For those going to research, QI, or the parent perspective, you'll see the instructions and the links in the chat box. Please use those now. Again, we'll come back together at 10 till. Thank you very much, everyone.